Hi, I'm Dr. Nelum. Welcome back to my YouTube channel. Today's video is COPD made easy. What is in the video? COPD definition, symptoms and signs, and important scoring systems. So this video will help you to study COPD more easily. I invite you to join and watch the rest of the video. So this is the first video of COPD series. I'm going to give you around 2 more videos later. So this first of all, let's focus on what to refer to study COPD. COPD actually you can read in Gold Guideline, and then you can read in Oxford Handbook, and if you have some handouts or PowerPoint presentations, I think it will be really easy to study, because COPD is a vast area and you can't skip COPD, because whenever you are studying for chest medicine, I think COPD comes in the top. So I think you should know it really well. So let's move on to my tips to help you to study COPD. So first of all, yes, it's COPD Gold Guideline. I have presented here. It's the latest one, a picture I have taken, 2020 report. It has 139 pages and it is a bit lengthy, but all the facts you need to know about COPD is there. So simply you can Google it and download. There's a pocket version as well, so you can read it. It is really well. And I'm going to give you few facts in this COPD Gold Guideline, and just going to help you to work out COPD bit more easily than the usual study method. So let's focus on to the definition of COPD. COPD definition, it's really bit long, and sometimes it's really hard to take it into your head. But I would like to suggest you just to underline a few important points here and take it into your head. So let's read the definition here. It says airway limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and the lungs to noxious particles or gases. So you can see there's some important points. First one is that it says there is airway limitation, and then it says it is progressive, and then it says there is chronic inflammatory response in the airways and the lungs, and it says it is because due to exposure to noxious particles or gases. So those points you have to take into your head, and I will be talking about those points a bit more in detail later. And there you have to note down in previous definitions they have included some other disease categories as well, 2 other disease categories particularly, that is emphysema and chronic bronchitis. I think you all have read these definitions earlier, and I think for me it has been really confusing always. However, I like this newer definition much better. So this emphysema and chronic bronchitis are airflow limited statuses contained within the disease status known as chronic obstructive pulmonary disease. However, these 2 entities are no longer considered in the new definition. So let's move on. So important points, as I mentioned here, the COPD is a chronic disease. So it says it is a long-standing disease, and it is progressive, and it has airway inflammation and limitation. These 2 points are really important when you're studying. So take into your head. There's airway inflammation and limitation, and there's exposure to noxious gases and particles. And what are they? That's like smoke. So basically it's all smoke. So it can be either cigarette smoke, biomass, or other smoke that's like work related. So I just simply ask you, don't just memorize all these definitions, because it's going to be a failure at the end. So just work your way down, so it will be helpful. And just see, it's like a long standing disease, and you can work out like for how long. And then you can see it says it's progressive, and you can just question yourself as like how. And then it says airways are affected, so you can work out, you can read around, so which airways. And it says there is inflammation, and where is the which airways are inflamed likewise. So those are whether it's small airways, large airways. Likewise, you can question yourself and you can find the answers. And um, and then you will really find the answers if you find like question yourself. And then ultimately you can simply work out the symptoms and signs. And yes, and then it will help you to work out the treatment if you know how the pathology works on. And then you can work out the symptoms and signs very easily, and then of course you can easily work out the treatment, so that you will need not to memorize the drug specially. And then ultimately it will heal your patients, and that is what the world needs. So let's move on. So usually you all know COPD has like chronic productive cough, and they have chest tightness, and they have breathlessness, and they have wheezing. Cough is actually in a COPD patients really typical. They have very chronic cough. However, they have very little sputum production, and they are not here. Those are usual sputum is colorless unless there is like a secondary bacterial infection. Usual COPD patients, they produce whitish sputum. These points are needed for your exam. And I have taken this picture from the Gold Guideline. They have incorporated these same symptoms with much bit of elaboration. There they said dyspnea is progressive over time, and they say it's characteristically worse with the exercise, and it is persistent. And then they say it's there's chronic cough and chronic sputum production. And there they have mentioned some other points as well, like the family history of COPD and childhood factors. They have mentioned low birth weight and childhood respiratory infections have two as key indicators for considering diagnosis of COPD. So this point is important when you're taking a long case history. Make sure to ask about birth history, like any history of low birth weight and significant respiratory infections in the childhood. This actually leads to impairment of lung development, and the researchers have found this impaired lung development later in adulthood can lead to COPD. So it's an important point to note here. And there's another entity that you have to like think of when before labeling a patient as COPD, because these cough, SOB, and wheezing can be present in asthma patients as well. So when there's like cough and SOB, you can't just label a patient as COPD. You have to exclude other diseases as well. So what comes in the top is asthma. However, in asthma, even though they have the similar symptoms, their symptoms are most of the time, like always, they have a diurnal variation. That means in the night and the evening, their symptoms are worse. Usual asthmatics are less than 40 years of age, and significantly they have atopy, like eczema, and history of allergies, history of history of significant allergies they have, and they have family history, and they have childhood nebulizations almost always asthma patients, and they are normal in between the attacks. When there's no hyperresponsiveness in their airways, they are normal. But COPD patients are not so. Always they're symptomatic, but asthma patients become normal in between. And asthma is usually not progressive. It is like it can go time to time, it can worsen, but the disease won't progress. That means the lung condition, lung damage will be static. There won't be any further lung damage or other organ system involvement. And significantly, they don't have the asthmatics. There is no much of a smoke history. However, there's another entity where the asthma and COPD present in one patient, that we call as asthma COPD overlap syndrome. So this one is also you have to read around, and this is also mentioned in the GOLD guideline. So let's move on to COPD signs. So COPD patients, I think you all know this, they have barrel chest, and most of the time because of their prolonged expiration, they have pursed lip breathing, and they have accessory muscle use as sternocleidomastoid intercostal muscle use. Likewise they have, and they have always tend to take a tripod position, and they have elevated JVP, and they have sometimes when there's like going to type 2 respiratory failure, like they will have cyanosis. And on auscultation, on percussion, you will find there's a hyperresonance, and if you auscultate very with the sound mind, you will notice that there is prolonged expiration. That is important on auscultating a COPD patient, and you will see the normal breath sounds are very distantly. You will not clearly hear it, but breath sounds are there, but the sound intensity is low. And there is when there's like exacerbation, you will find wheezing, polyphonic rhonchi will be there. And if you auscultate in the pulmonary area, when there's like heart failure, you will hear a loud P2. And then there's the end organ failures, you will see like heart failure signs like bilateral ankle edema, and shift of apex beat you will find. So here's a chest x-ray of COPD patient, and there's a left side there's a normal chest x-ray PA view, and the right side there's a COPD patient's chest x-ray. And this chest x-ray you can see there's like I think you can see the lung fields are much more dark, and the diaphragms are flat, and the mediastinum is elongated, and the lung vascular markings are faint. I think you can recognize it. The lungs are black, diaphragms are flat, mediastinum is elongated, and the vascular markings are not prominent. So these findings I think you should know when you need to identify a COPD patient with a characteristic history. So first I think you know the pattern, you have to work out the symptoms and the signs, history, examination, and the investigations. Chest x-ray comes on top, and these are the findings you will see in a chest x-ray of a patient with COPD. So then what the most importantly you should know about spirometry. I have taken this picture from the COPD guideline, GOLD guideline, a normal trace and a obstructive disease trace. This is like not the exact like this can vary, but this is the spirometry of a obstructive disease. I think you know COPD is a obstructive disease. So there will be a FEV1 to FVC ratio below less than 70%. That is the marker for to tell you as obstructive. But these curves you won't see very clearly in your clinic setup, because our patients have some other they can have dual pathologies, maybe some other pathologies and some structural defects of their lungs. And likewise, these clear-cut spirometry readings you won't be getting, but for your knowledge, I think this is important. This will be of the basic trace of an obstructive disease. And here, of course, I think you should find out, like, if there's like this spirometry value we take as pulse bronchodilator value, that you have to know. And then let's move to important tools and scores. So important tools here, you should know the goal staging, and then you should know the refined ABCD assessment tool and MMRC score and CAT score. So I think you all know, following taking a spirometry that is based on post bronchodilator FEV1, there are 4 categories of COPD: Gold 1, Gold 2, Gold 3 and Gold 4. So Gold 1 will be FEV1 of more than 80%, that is mild obstruction. Gold 2 is moderate obstruction, that is 50 to 80, and Gold 3 will be severe, that is FEV1 is in between 30 and 50, and very severe obstruction will be when there's FEV1 less than 30%. I think you should just read around this, and you should have it in your mind. These gold stages are important in your MCQs. And then I told you, so you do a chest x-ray, then you do a spirometry, and then you grade as Gold 1, 2, 3 and 4. And there's another important assessment tool, that is refined ABCD assessment tool. I think you already know this stuff, but I have included here. So you have for other categories as well, apart from Gold 1, 2, 3, 4, that is Gold A, B, C and D. For your exam purposes, you should know how to draw this picture. Where you should really know where the A lies, B lies and C lies and D lies. Don't just mess it up. There's an order for that. And this comes with symptom burden and the hospital admission. Symptoms burden goes in the x-axis, and the hospital admission goes in the y-axis. Symptom burden is measured with MMRC score and CAT score. Hospital admission is just hospital admission. So it says 0 or 1 or not leading to hospital admission will belong to A or B. More than 2 or 1 leading to hospital admission, that is like exacerbation history. When there's like that, those patients will be categorized to C and D. And then there's MMRC scoring, that's a modified MMRC score. And then it says 0 to 1 in A and C. When there's MMRC of more than 2, that those patients belong to B and D. So these two scores you have to read and take it into your head. So I have incorporated a modified MMRC dyspnea scale here, 0 to 4. So 0 comes when there's patient gets breathless in strenuous exercise. Grade 1 when walking up a slight hill, and 2 walk slower, and when 3 comes when the patient tend to stop at 100 meters, and 4 comes when the patient is unable to leave house. And the CAT score comes out of 30 sorry. And likewise you can read that as well. You can just memorize it, I think, but for the time being I think I usually memorize MMRC grading. CAT score is a bit complicated, but you can read that as well. So I will yeah, that's all for the video today. It's not of that of a long one. Just memorize, just work out the COPD definition, the signs and symptoms, X-ray findings, and the spirometry. Study around spirometry. Study gold staging, MMRC staging, CAT score, and the refined assessment tool for the time being. I will come to you in the next video with COPD pathophysiology and the treatment and all the stuff. But basically for the 2021 DTCD selection exam, I don't think there's like need of pathophysiology in much detail. If you know these basic stuff, I think you can work out many, and especially the treatment. So thank you for listening and watching my videos. I think it's helpful. So see you in next video. Just keep in touch.